Hello dear students, welcome to NEET PG 2024 recall session for biochemistry. As you went through the two sessions of NEET PG exams, you do realize that biochemistry, hardcore biochemistry as questions were slightly lesser, but biochemistry became a part of a bigger group of clinical diseases. Many of the questions were not directly biochemistry, some of them were very strongly integrating themselves with other subjects also. So in most of the MCQs that we've collected for this NEET PG recall session, some of them would actually tell you that those questions can take you to even deeper places in your clinical knowledge. Now, some of them may not have all the options for the same question. Some of them don't have any options at all in the questions I'm going to present you, but I'll give you the most important concepts that are required for you to go through them so that you will be able to crack the same kind of questions or similar questions or the questions from the similar topics in the upcoming exams beautifully well. Now, let's begin with the first question. Anemia plus neutropenia plus absence of skin pigmentation, which nutrient deficiency? See, the moment I see skin pigmentation getting absent, I think of decreased melanin. And among the three options I know, melanin synthesis starts from tyrosine pathway, and the element that is required in the tyrosine pathway obviously is copper. Why? Because copper is the cofactor or the core metal present in case of the rate limiting enzyme called as tyrosinase. This tyrosinase is not the same as tyrosine hydroxylase. When tyrosine is acted upon by tyrosinase, it takes the pathway into dopaquinone indolquinone pathway or dopaquinone pathway as such. This dopaquinone pathway will take you forward to melanin synthesis. So in case of deficiency of copper or in case of deficiency of tyrosinase, you will be having graying of hair happening faster for people. At the same time, absence of skin pigmentation can also be noticed. At the same time, absence of color of the iris also can be seen. Now, why neutropenia happens in copper is not very strongly proven, but there is a statement saying that zinc induced copper deficiency can lead to neutropenia consistently. Studies have shown, even though the exact reason is not specifically known, how copper is causing neutropenia, zinc induced copper deficiency can cause neutropenia. The same zinc induced copper deficiency can cause anemia. How is copper deficiency causing anemia? Remember, zinc and copper compete with each other at the divalent metal transporter level. Now, when zinc is in excess, then absorption of zinc will inhibit the absorption of copper, because of which copper deficiency can be seen. But at the same time, the opposite concept should be taken into consideration. Iron deficiency can lead to copper deficiency also, even though ferrous ion called as Fe2 plus and cupric ion called as Cu2 plus, both of them may come to a conclusion that they can actually require the DMT for transport. There is an understanding that iron deficiency can lead to copper deficiency. So when a patient is having copper deficiency, it can conversely cause iron deficiency also, because of which heme synthesis can be affected, anemia can be noticed. When you put all the three together, anemia, neutropenia and absence of skin pigmentation, the one and only choice of deficiency of nutrient has to be copper. Now look at this question. A patient presents with hyperpigmentation along with Mees line. Which poisoning do you suspect? Alries Mees line obviously is a chronic arsenic poisoning, which you have learnt in toxicology also. Remember, hyperpigmentation with Mees line, I told you, right? What are the Mees lines? The transverse white lines on the nails that you see are characteristic of chronic arsenic poisoning. What are the key features of arsenic poisoning? Apart from Mees lines, you will be able to notice skin manifestation, where you see raindrop pigmentation of skin present on the trunk and extremities. Hyperkeratosis can be noticed, especially in those areas where we come in contact with objects, for example, the palm and the soles. Other symptoms can be GI disturbances. Any kind of metal poisoning is capable of causing GI disturbance, and heavy metal poisoning is capable of causing renal tubular failure also. Why? Because renal tubules are capable of having receptors to reabsorb or to secrete any kind of compounds during the urine formation. Those renal tubules will be having receptors, I told you, right? Those receptors are like transporters, which will be just proteins who depend on disulfide bonds. And when you have heavy metals coming and distracting and disturbing these disulfide bonds, then the secondary and tertiary structure of those proteins will be demolished, because of which renal tubular failure can be noticed. Neuropathy can be noticed and anemia can be seen, because of which you will be having arsenic based anemia also. Now, this was the clinical case discussion where failure to thrive and jaundice was given in an infant, and hepatosplenomegaly was noticed along with infantile cataracts. Obviously, if they say infantile cataract, you can ask yourself one more question: what kind of cataract it is? It can be oil drop cataract, and that will tell you about the diagnosis called as galactosemia. And if it is galactosemia, the students have told me that in the particular question, instead of saying galactosemia, they have given all the clinical features, and they said the urine was positive for Benedict's test, but it is negative for ketones. See, if urine is positive for Benedict's and also for ketones, there is a possibility that it can be DKA. The urine is negative for Benedict's and positive for ketones, it can speak about starvation. That is, if glucose is found in the urine along with the ketone bodies, it is diabetic ketoacidosis, uncontrolled type 1 diabetes mellitus. If glucose is not found in the blood but ketones are found in the blood, it is purely ketonuria but no hyperglycemia. It can speak about starvation. Now, the Benedict's test is positive, ketone bodies are negative, but the Benedict's test is not because of glucose. Then you can think of other monosaccharides like fructose and galactose. But if they mention infantile cataract and jaundice, you will think of galactose. And in case of fructose metabolism, hereditary fructose intolerance involves aldolase B deficiency, where the clinical differentiation between the both will be fructose will be found in the urine because of hereditary fructose intolerance and higher accumulation of fructose 6 phosphate or fructose 1 phosphate can be accumulating. That is the condition which can lead to hepatic failure and cirrhosis, where the clinical history would be written as the child is not able to tolerate fruit juices. If it is fruit juices intolerance, then the problem is with fructose. If it is with mother's breast milk intolerance, breast milk contains lactose, lactose breaks into glucose and galactose, so galactose is not tolerated, then it is a classical case of galactosemia. But galactosemia can be again divided into classical and non-classical, out of which classical is the severe version, and in case of classical galactosemia, the deficient enzyme is galactose 1 phosphate uridyl transferase. When it comes to non-classical galactosemia, it can be galactokinase deficiency or galactose epimerase deficiency, that is UDP, galactose epimerase deficiency. So the epimerase enzyme deficiency or galactokinase deficiency will be non-classical with less severe symptoms, while if it is galactose 1 phosphate uridyl transferase deficiency, it is classical galactosemia, which is very severe kind of symptoms. And remember, along with this, recurrent E. coli sepsis can be noticed, because the galactose and lactose becomes very important feeding source of nutrition for the E. coli bacteria. Okay, look at this question. Students gave me a very complicated form of telling the question, but ultimately I thought I'll discuss the concept with you. So I have just put in one single sentence: vitamin required in methionine metabolism. Remember, yes, adenosine methionine is referred to as the active form of methionine. It means first methionine is converted into S-adenosyl methionine by utilizing ATP, where the adenosyl group is taken by the methionine onto the sulfur atom, so it becomes S-adenosyl methionine. Now this S-adenosyl methionine is right now capable of releasing the methyl group very easily, so when it is getting demethylated, it becomes S-adenosyl homocysteine. Now, this S-adenosyl homocysteine can lose the adenosyl group to become homocysteine. So, do you understand the transition? We start with methionine, This methionine is a sulfur containing amino acid, but the sulfur is not free. Now this sulfur is holding on to the methyl group very strongly. It is not releasing the methyl group. So if you want the methyl group to be knocked out of the hands of sulfur, you load the methionine with an adenosine group. So when the adenosine group is loading the methionine, the methyl group is very difficult to be held on by the methionine. So methyl group becomes easy to be lost. When the methyl group is lost, the S-adenosyl methionine becomes S-adenosyl homocysteine. So methionine is transformed into homocysteine. Now when you lose the adenosyl group, what is left is just homocysteine. So we have come from methionine to homocysteine. Next step is homocysteine will react with serine in the presence of an enzyme called as cystathionin beta synthase. That will give you a compound called as cystathionin. Now this will be acted upon by the enzyme called as cystathionin gamma lyase. That will break the cystathionin into homoserine and cysteine. Now this is the seamless transition between methionine becoming the source of cysteine. It means cysteine is not an essential amino acid as long as methionine is taken in the food. Methionine is an example of an essential amino acid. When you have enough amount of methionine, you can synthesize cysteine. And now, methionine can be converted into homocysteine. Homocysteine reacts with serine to form cystathionin. Cystathionin breaks to become homoserine and cysteine. Now, in this area, the adenosyl group was offered by ATP. Now, this methyl group offered by methionine should be taken by any kind of compound called as X, which becomes methylated X. At the same time, that methyl group can be carried by tetrahydrofolic acid to become methyl tetrahydrofolic acid. Or this methyl group can be taken up by B12, which is getting converted into methyl B12. So in conditions where you don't have enough amount of substrates which are requiring methylation, then the best kind of vitamins which can support the conversion of S-adenosyl methionine to S-adenosyl homocysteine can be folic acid called as vitamin B9 and cobalamin called as vitamin B12. So these two vitamins can help in the conversion of S-adenosyl methionine to S-adenosyl homocysteine. Now, the homocysteine can become cystathionin in the presence of this enzyme, which is supported by vitamin B6, referred to as pyridoxal phosphate. The active form of B6 is pyridoxal 5-phosphate. The same pyridoxal 5-phosphate is also required for the cystathionin gamma lyase. So, when you want to metabolize homocysteine converted into cysteine, you require the services of B6. When you want to convert methionine into homocysteine, you require the services of B9 and B12. So these are the three vitamins importantly involved in the methionine metabolism. Now look at this question. 40 to 50-year-old alcoholic with nausea, vomiting and confusion. Some students said the clinical features resemble delirium tremens, but ultimately it is an alcoholic case. And this person, if he's having nausea, vomiting, and confusion, then he may not be an acute alcoholic person. It may be a chronic alcoholic person. And they said they estimated the blood glucose to be 40 milligrams per deciliter. Hypoglycemia is noticed. So what is the next best method of management? Now, if you go for dextrose infusion, some students said because hypoglycemia is more life-threatening, you have to load the patient with glucose, because if you don't give enough amount of glucose, the patient can die because of hypoglycemia itself. But there is another parallel thought process that has to be run here. When you think of hypoglycemia and load the patient with glucose, if the patient is chronic alcoholic and he is having chronic alcohol-induced B1 deficiency, then this B1 called as thiamine is not available to support a complex called as PDH complex. Here you have to bring your A game into the equation. PDH complex is made up of three enzymes. Who are the three enzymes? According to the name, PDH itself is one of the enzymes, pyruvate dehydrogenase. Then you have dihydrolipoyl dehydrogenase and dihydrolipoyl transacetylase. Then you have five coenzymes. And the 5 coenzyme starts with B1, which is thiamine pyrophosphate. You have B2, which is riboflavin, active form is FAD. You have B3, which is niacin in the form of NAD. And we have B5 in the form of coenzyme A, pantothenic acid. And you also require lipoic acid. So 5 coenzymes B1, 2, 3, 5 and lipoic acid, out of which B1 deficiency is very obvious in alcoholics because an alcoholic person has two problems. One, because he has taken alcohol, which is 100% calories but 0% nutritional value, the patient will have loss of appetite. He has taken high calorie liquid, which is alcohol, so he has loss of appetite. Because he has loss of appetite, the moment he drinks fully, he will not have the hunger to have proper food. Because proper food is not taken, he has decreased nutrition. Now, even though he forces himself to eat properly or somebody else is forcing him to eat properly, still alcoholism will block absorption of vitamin B1, because of which chronic alcoholics suffer from B1 deficiency. That can be seen as chronically, it can be beriberi, and if the chronic disease has an acute attack, it can be Wernicke-Korsakoff syndrome. Wernicke's encephalopathy and Korsakoff psychosis. So, what are the clinical features of Wernicke-Korsakoff syndrome? You can have global aphasia, ophthalmoplegia, ataxia, mental changes or poor mentation, and peripheral neuropathy features. These can be noticed. Now, it can be beriberi or it can be Wernicke-Korsakoff syndrome. Now, in this condition, you are actually having a confusion. For the acute hypoglycemia, should I go for dextrose? If you give dextrose, which is glucose, when B1 deficiency is seen, then the glucose which enters into glycolysis to produce pyruvate will not be able to go to the next step of acetyl-CoA formation, which is governed by the integrity of PDH complex. If PDH complex is intact with all the 3 enzymes and 5 coenzymes, pyruvate can become acetyl-CoA. Acetyl-CoA enters into TCA cycle where you can produce 10 ATP molecules for one cycle of TCA. But because PDH complex is affected because of B1 deficiency, then pyruvate is unable to go into acetyl-CoA. So pyruvate will take the alternative pathway of becoming lactic acid. So if you give only 25% dextrose, then the patient may suffer from lactic acidosis and seizures. So that is why first you inject the patient with thiamine and then load the patient with 25 dextrose. This is the best treatment for this given condition. Okay. Now, the question paper says a teenager with complaints of skin lesions over the upper limb with keratotic changes, what can help the patient is what they said. Some students said it was a case of rhinoderma. In both the situations, if the skin is not actually smooth, it is having a keratotic change. It means turnover of epithelia is failing. Turnover of epithelium on the skin and mucosa is governed by retinoic acid vitamer of vitamin A. There are 3 vitamers of vitamin A. It can be retinal, retinol. Both of them are involved in Wall's visual cycle at the level of retina. While the epithelium on the skin, mucosa, cornea and conjunctiva are all governed by the retinoic acid version. So, when there is a vitamin A deficiency and retinoic acid is poor, then turnover of epithelium will not happen. Accumulation of the same kind of epithelial cells can happen. Sharper and rougher kind of skin happens. So, toad skin may be present or keratotic changes can be seen. At the same time, proper turnover does not happen at the level of cornea and conjunctiva, bitoid spots, xerophthalmia, zero. This all can happen, because of which blindness can happen. So in those patients, vitamin A can be very helpful. B complex vitamins, especially in case of niacin and riboflavin, skin changes may be reversed because of their deficiency. Now look at this case. A patient is vomiting. Some students said the patient is diabetic. Some students said they don't remember whether he was diabetic or not. The ABG values were given. The ABG values suggest pH of 7.2, PCO2 16, bicarbonate 6. These are the sodium, potassium and chloride values. Now these 3 values we can take it further and do it later, but focus on the pH. If the pH is 7.2 and if he is vomiting and he is having diabetes, then you can think of diabetic ketoacidosis as a feature. I'm not saying it is the diagnosis, I'm just taking it into consideration. If that is the case, then the primary problem can be metabolic acidosis. Generally, you have understood it as acidosis. It is acidosis. Current pH is 7.2. So it is acidosis. Now, the options are having obviously acidosis in every step. So you have to find out whether metabolic acidosis is the primary problem or respiratory acidosis is the primary problem. If the vomiting is not very severe, then you can rule out alkalosis. Now, because he may be diabetic and because the bicarbonate is 6 and PCO2 is 16, then I can think of metabolic acidosis. Now, some students will have a question. See, if metabolic acidosis is the primary disorder, then the secondary compensation will be the opposite of both the terms. The opposite of metabolic is respiratory. The opposite of acidosis is alkalosis. So, the compensation for metabolic acidosis can be respiratory alkalosis. Here, you can take into consideration metabolic acidosis and respiratory alkalosis. How do I say it is metabolic acidosis? Because bicarbonate is 6. Bicarbonate is the metabolic parameter. I call it as metabolic acidosis. What about the respiratory parameter PCO2? See, respiratory parameter PCO2 normal value is approximately 40 millimeters of mercury. Now, when will you call it as respiratory acidosis? Only when the PCO2 values are more than 40 millimeters of mercury. Here, the PCO2 values are less than 20, that is, it is 16. So, we'll make it a point here. PCO2 values are less than 40, so acidosis is not because of respiratory problem. Bicarbonate normal value should be 24 to 26, and because it is less than 6, you can easily say bicarbonate being the base, the acidosis is because of metabolic parameter. So now we have established that the primary problem is metabolic acidosis. If at all I had to say it is respiratory acidosis, then bicarbonate values may be slightly higher, but PCO2 value should be even more higher. Now, why the PCO2 value is lesser? Because there is a rule. Whenever there is a primary disturbance, the secondary compensation will happen in the same direction as the primary disturbance. So here the primary disturbance is bicarbonate, the direction is less, that is downstairs. The secondary compensation is not through bicarbonate but through PCO2. So PCO2 also should fall. So compensation is happening. So metabolic acidosis, mild respiratory alkalosis, compensation is seen, but because acids are accumulating, you can call it as high anion gap if it is diabetic ketoacidosis. If acids are not accumulating, but if at all you look at the anion gap area, you have to calculate for anion gap to say whether it is high anion gap or low anion gap. What is the anion gap? Sodium plus potassium minus of bicarbonate plus chloride. I don't want to argue over the values that are given here. Let me tell you, if sodium and potassium put together is X and bicarbonate plus chloride put together is Y, then X minus Y should be approximately equal to values between 8 to 12. If this value after calculation of sodium, potassium, bicarbonate and chloride is more than 12, you call it as high anion gap metabolic acidosis. If it is 8 or somewhere in the region of normal, you call it as normal anion gap. So depending upon what the values are given in a question paper, you can go for the answer. Now look at this question. A man presents with hemoglobin of 7.8. So this indicates the patient is having anemia. Low MCV, low MCH means to say that it can be microcytic hypochromic, because the mean corpuscular volume and the mean corpuscular hemoglobin, both of them are lesser. Low serum iron, reduced transferrin. When the iron is lesser, then the transferrin is also lesser. And iron binding capacity is higher. When the iron is so less, the hunger for the iron is very high from the body. So iron binding capacity is high by the body. So it's a clear case of iron deficiency anemia. No more questions about it. Now, the deposits seen in Alzheimer's disease. See, you will be confused as something called as tau proteins also exist, which can actually speak about neurofibrillary tangles, right? You have also learned about the Alzheimer's disease in lipid metabolism. Can you recollect where? When you speak about the defect in apoprotein E. Remember, this is another MCQ to expect in the upcoming exams. Apoprotein E defect is related to Alzheimer's disease. At the same time, beta amyloid deposits can be seen in Alzheimer's disease. In Alzheimer's disease, you have to understand alpha helices and beta sheets are examples of secondary structure of proteins, and the secondary structure of proteins in the brain, alpha helices in neuronal cells can easily be digested. But if the same alpha helices are slowly converting themselves into beta sheets, then lysosomal degradation of the beta sheets is very poor, because of which these beta sheets will start depositing. So deposition of these beta sheets can also be an indication of defective digestion of proteins. In case of Alzheimer's disease, it is beta amyloid protein. Now look at this. The beta amyloid deposits form amyloid plaques in the brain, which are the hallmark of Alzheimer's disease. Apart from that, neurofibrillary tangles, which are composed of hyperphosphorylated tau protein. You take a tau protein and attach phosphate and keep on attaching more and more phosphates. Hyperphosphorylated tau protein will actually be responsible for Alzheimer's pathology. Now, what about alpha synuclein? Alpha synuclein is related to Parkinson's disease, not with that of Alzheimer's. And the alpha synuclein is also implicated in other synucleopathies. The remaining two options are not known. That is why I'm not able to make a comment. So remember, both tau protein and beta amyloids can be related to Alzheimer's disease. Now look at this question. Methanol contaminated alcohol consumption that lead to a patient's diminished vision and abdominal pain. See, normally whenever you think of illicit liquor, there is a very good chance the ethanol present in the liquor can be contaminated with methanol. The formula for methanol is CH3OH. The formula for ethanol is CH3CH2OH. Now, thinking in a biochemical aspect way, you can say whenever alcohol is ingested by the human being, the metabolic pathway is similar for both ethanol and methanol. The first step is oxidation of an alcohol to convert it into aldehyde. So here it is ethanol that becomes acetaldehyde, which is a 2-carbon aldehyde coming from the 2-carbon alcohol called as ethanol. If it is a 1-carbon alcohol called as methanol, it gives rise to 1-carbon aldehyde called as formaldehyde. So, in case of the high a person experiences after taking alcohol is because of acetaldehyde. The clinical features of diminished vision and abdominal pain in methanol ingestion is because of formaldehyde. The next step is acetaldehyde becoming the 2-carbon respective acid called as acetic acid, and the formaldehyde becoming the 1-carbon acid called as formic acid. So, when the question is asking for the methanol can give rise to what in the blood, formic acid has to be an obvious answer. Formic acid and formate both mean the same. The one option which is absolutely wrong is option B. Why? Glycolic acid and oxalic acid has been mentioned. Glycolic acid and oxalic acid are byproducts of not ethanol or methanol. It is byproduct of ethylene glycol. Ethylene glycol undergoes multiple metabolic steps with metabolites called as glycolic acid and oxalic acid. These are the acids primarily responsible for the acidosis. At the same time, the oxalic acid is capable of causing calcium oxalate crystals, which leads to nephropathy that may lead to renal injury. So, the glycolic acid and oxalic acid, both of them are not taken into consideration. Now, any kind of alcohol ingestion can lead to acid formation. Now, in case of your ethanol excess, whenever acid formation happens, your body will have slightly higher levels of H+. So, in the kidney, H+ excretion has to happen. In that area, reabsorption of lactate ions may happen, where there is an exchange for the proton with that of lactate. So, in that aspect, formic acid plus lactic acid accumulation can be noticed. And when ethanol has been consumed, the oxygen metabolism may be slightly altered, because of which mild anaerobic glycolysis may happen, because of which you will be able to have lactic acid accumulation. Glycolic acid, oxalic acid formation is not a property of methanol poisoning. So for this question, I would choose formic acid and lactic acid. Now have a look at this. When it comes to metabolic acidosis with high anion gap. You can think of lactic acidosis, ketoacidosis, renal failure, toxic ingestion of ethylene glycol, methanol poisoning, salicylic acid overdosage, rhabdomyolysis, uremia, and inborn errors of metabolism. These have been asked so many times in the exams. Young boy presents with some clinical features for which bone marrow biopsy, histopathological examination of tissue macrophages were seen. Students said they saw crumpled tissue paper appearance in the tissue macrophages like this. When you know it is crumpled tissue paper appearance, it is a classical case of Gaucher's disease. And if it is Gaucher's disease, then the bone marrow will have change, which will be referred to as Erlen-Meyer flask deformity. And students said that in this question they had actually spoken about the Gaucher's disease and they had asked for the genetic defect, but all the four options given were not genes, it was the enzyme. So obviously the answer has to be glucocerebrosidase. How sphingomyelinase is involved, how hexosaminidase is involved, all these come under lysosomal storage disorders and lipid storage disorders, and we have discussed this threadbare in the classes. Please go back and check the lipid storage disorders in Manipal Meddays app for a very clearer, brisk understanding. In a half an hour video, I have told you in and out of how to actually go for the exact answer for enzyme versus disease and clinical features. You will actually benefit from that. See, hexosaminidase A and B, hexosaminidase A, what is the disease? Sphingomyelinase, what is the disease? What is Niemann-Pick's disease? All these things will be taught very carefully. In this case, for Gaucher's disease, it is glucocerebrosidase defect. Okay, now look at this question. A 10-year-old child with complaints of rash on exposure to sunlight on sun-exposed areas. There is some problem in the cornea also, they said. It is a defect in one of the DNA repair mechanisms. See, these are the four types of DNA repair mechanism. But when they say exposure to sunlight, it is causing skin rashes, then I would suspect xeroderma pigmentosum. And if I suspect xeroderma pigmentosum, then the DNA repair defect is nucleotide excision repair defect. Sun exposed areas are the ones who are having rashes after exposure to sunlight. It's a very simple case. We have discussed molecular biology in detail and I have told you about xeroderma pigmentosum as a part of nucleotide excision based repair. We have taught mismatch repair, basic gene repair, homologous recombination, heterologous arrangements and all in detail. Have a look at them. Now this was the picture given. What is the source of thiamine? In that they had marked rice and roti and there was curd also. They had spoken about dal and cucumber. These were the options given. Remember, thiamine's best source can be yeast and parboiled rice or husk containing rice. The rice where the husk is not removed. These are the best sources of thiamine. Now, curd is a rich source of casein protein. It is also a rich source of lactose, which is fermented. So lactic acid can be seen, lactobacilli can be seen, which can be good source of commensal bacteria for the GIT. Dal is a good source of proteins made up of pulses. Try to remember cereals plus pulses will be helpful for going for a combination activity of amino acids where lysine deficiency and methionine deficiency can be overtly compensated by each other. Cucumber is a vegetable. It is capable of carrying a lot of water with some soil minerals. And remember the South Indian thali or the Indian thali which contains rice or roti, sabzi, curd, and that of other small kind of vegetables will be the best form of complete meal. Why? Because the rice will contain carbohydrates and they will be going for carbohydrate metabolic process. The dal will have proteins and both of them will carry lipids. They all have to go through metabolic processes. Whenever metabolic processes and pathways have to happen, you require enzymes and coenzymes and cofactors. While the enzymes can be derived from the proteins, the coenzymes are nothing but B complex vitamins and vitamin K, while the cofactors are the minerals. They are abundantly available in the vegetables only. So vegetables are the most important component of micronutrients to metabolize the macronutrients in the same thali meal. After gastrectomy for gastric carcinoma, which vitamin supplement is required? When a gastrectomy is done, the stomach being the source of oxyntic cells and parietal cells, where the intrinsic factor of Castle is generated, is flopping. If intrinsic factor of Castle is not available, then binding with the extrinsic factor of Castle called as vitamin B12 does not happen. Now remember this beautiful concept. When it comes to B12 absorption, the intrinsic factor and extrinsic factor, both of them have to form a complex, and in the intestine, remember, folic acid is absorbed in the jejunum. Ileum is the place for vitamin B12 absorption. Duodenum is the place for iron absorption. All three are involved in RBC's health. Now look at this. In case of ileum, the B12 absorption can happen only when they are complex with that of intrinsic factor of Castle. The extrinsic factor of Castle is vitamin B12 itself. So vitamin B12 cannot be absorbed just like that. Only the intrinsic factor, extrinsic factor complex can be absorbed. So if gastrectomy is done, then you are not able to synthesize intrinsic factor of Castle, because of which vitamin B12 absorption can fail. So you have to supplement the patient with vitamin B12, mostly in the parenteral fashion, especially IM methods. A young child, a picture of KF ring was seen. That is what they said. A slit lamp examination was done, and you had a golden yellow ring around the cornea, which was suggestive of KF ring. So students said Wilson's disease was suspected. If you want to go for confirmation of Wilson's disease, the best way of confirming it is taking a liver biopsy and estimating the copper present inside the hepatic cells. So hepatic copper estimation after taking liver biopsy is the best way of confirming Wilson's disease. And they had said MRI. MRI findings may be present, but you cannot actually confirm it as Wilson's disease. You may actually speak about the lenticular degeneration part, but lenticular degeneration may be caused by other reasons also. So hepatolenticular degeneration is the other name for Wilson's disease worst case scenario. If you want to confirm it as Wilson's disease where copper is in excess, you go for hepatic copper. But after you have started the treatment for the patient on Wilson's disease with trientine in case of severe cases, or zinc in case of moderate cases, or D-penicillamine according to the older prescriptions, then if you want to monitor the success of the treatment, then you can go for serum ceruloplasmin or serum copper. At the same time, urinary excretion copper also can be effective. Now if you want to go for definitive methods, molecular diagnostics can be done. Molecular diagnostics are definitive but extremely costly. You don't have to do that. Instead, liver biopsy for hepatic copper would be good enough to confirm the diagnosis of Wilson's disease. A patient with chronic maize intake presents with diarrhea, dermatitis, dementia. This is what we've been learning from childhood and school. 3D disease has now one thing added, death. So now it has become 4D disease. 4D disease is nothing but pellagra. Do you remember most of the skin lotions which are actually being advertised as photoprotective, they say it contains niacinamide? It is because niacinamide, which is vitamin B3, and riboflavin, which is vitamin B2, both of them have photoprotective effect. So when a patient is having B3 deficiency, then photoprotective effectiveness comes down. So on exposure to sunlight, the sun exposed areas will go for deep pigmentation causing dermatitis. For example, in the V shape of the human neck, where there is exposure to sunlight, you can have dark pigmentation, which is referred to as Casal's necklace. And because this particular B3 is also important for running the PDH complex and other kind of enzymes that are running carbohydrate metabolism, lipid metabolism, and protein metabolism in the form of NAD, the enterocytes, which are rapidly turnover causing cells, they suffer, because of which diarrhea can be seen. Dementia can also be noticed. Chronic maize would mean to say the patient will be having tryptophan deficiency, because of which B3 synthesis by the patient can be lesser. So niacin is the answer for the question. Look at this. A patient with hemoglobin of 7 gram percentage, tingling and numbness on both the legs, polyuria, weight loss. See, whenever a patient has multiple myeloma, because of which calcium sequestration happens or hypercalcemia happens, anything may happen, the fluctuation of calcium is also capable of causing tingling and numbness on the neurological area. Now, SACD is subacute combined degeneration of spinal cord, which can be because of severe B12 deficiency. Now they're asking whether it is multiple myeloma with renal failure or SACD with B12 deficiency or SACD with secondary diabetes. If this was the scenario, just like that, you could have easily spoken for SACD with secondary diabetes because the patient is presenting with polyuria and weight loss. And remember, in all these conditions, polyuria is a non-specific feature. Weight loss may be a more specific feature. That's all, but not a specific feature. Here, when they showed you plasma cells or MOT cells, then the diagnosis is tilting directly towards multiple myeloma. And if the multiple myeloma has been there for a long time, the light chain deposition in the glomerular basement membrane is capable of destroying your kidney to cause renal failure. So, the multiple myeloma is also capable of causing renal failure, right? When the kidney is failing for a long time, erythropoietin synthesis also will fail, because of which erythropoiesis can fail, because of which anemia of chronic disease can be seen as 7 grams percentage of hemoglobin. And remember, multiple myeloma with renal failure can be the answer if you see plasma cells or MOT cells. But here, if they had not given this picture, then most probably you can settle for subacute combined degeneration with secondary diabetes caused by subacute combined degeneration. Have a look at this. SACD is a neurological complication of B12 deficiency that leads to degeneration of spinal cord. Polyuria and weight loss are classical symptoms of diabetes indicating secondary diabetes. Okay. The patient was not very old but had complaints of abdominal pain, features of pancreatitis, blood was drawn, triglycerides were more than 2000 milligrams per deciliter, which apoprotein defect is seen. Many students came and told me, sir, yes, it is B48, sir. B48, I asked them, why did you choose that? They said, when triglyceride levels are so high, it can be a classical case of hyperchylomicronemia. Chylomicrons carry dietary triglycerides. So the chylomicrons will be rich in ApoB48, where in the enteric epithelial cells, the mRNA editing happens, because of which B100 gene has been truncated to B48 gene to accommodate this dietary triglycerides. That is why we chose this, is what they said. So this is a very easy place where you can make mistakes. See, they have not told you it is a classical case of hyperchylomicronemia, which is familial. This is not familial type 1 dyslipoproteinemia A. This is type 1B, not familial, it is monogenic. And here, in case of hyperchylomicronemia, the defect is not in ApoB48. Imagine if ApoB48 was defective, then dietary triglycerides are not at all absorbed. If they are not absorbed, then triglyceride levels, how can they cross more than 2000? So that is not the problem. In hyperchylomicronemia, the problem is in lipoprotein lipase deficiency. Because it is deficient, you are not able to handle the triglycerides easily. Now, in case of type 1B monogenic hypertriglyceridemia or chylomicronemia, you have ApoC2 defect. ApoC2 is the defective one. We have discussed this in and out, and we have discussed about the Fredrickson's classification of type 1, type 2 AB, type 3, type 4, and type 5. Type 1 and 5 can be involved in triglycerides. Type 3 and 4, you can actually speak about remnant diseases. Remnant diseases means you can speak of VLDL becoming remnant VLDL. You can have chylomicrons becoming remnant chylomicrons. So when the conversion of VLDL to remnant VLDL or chylomicron to remnant chylomicron, that is referred to as remnant disease. So they are also noticeable. Now this is a case of ApoC2 defect. Now, there was a similar question on lipoprotein metabolism, dyslipoproteinemias. A family history of coronary artery disease is noticed and tendon xanthoma is noticed. Some students said it was the Achilles tendon. Some students said don't remember whether it was Achilles or any other tendon. If they say tendon xanthoma, if they say palmar xanthoma, and if they say tuberous xanthoma, which is clear yellowish. Then the xanthoma pigmentation, pigmented swelling, is accumulation of cholesterol. But if they say eruptive xanthoma, then that indicates accumulation of triglycerides inside the xanthoma. So we have palmar xanthoma, tuberous xanthoma, and tendinous xanthoma. In these areas, it has to be cholesterol. Now they say there is a family history of coronary artery disease. So this is a familial hypercholesterolemia condition. And if it is familial hypercholesterolemia, which type of reduction classification? It is type 2A. And what is the reason for type 2A? It is LDL receptor defect. That is, if in the liver the receptor meant for the LDL is not actually proper, then LDL is not taken up by the liver, because of which LDL circulates in the blood. So LDL receptor defect will lead to LDL cholesterol level rising high and high. So normally optimally it should be less than 150. In this patient, more than 200 milligrams per deciliter can indicate there is a LDL receptor defect. Lipoprotein lipase defect is seen in case of type 1 hyperchylomicronemia. An infant with clinical features of fever and CNS features are noticed, had bilateral chorioretinitis and intracerebral calcifications and hydrocephalus. Some students said it may be a biochemical condition also, but mostly it is a question of microbiology. We have discussed this in microbiology. This is a case of toxoplasmosis. Okay. Now, some students said cardiac issue suggestive of hyperhomocysteemia. Cardiac issue or cardiovascular issue, I'm not very sure. If there is hyperhomocysteemia, remember homocysteine will interfere with the fibrillin meshwork, because of which fibrillin containing areas or fibrillin dependent strength based areas will suffer. For example, the suspensory ligaments of the lens or blood vessel wall formation will be interfered with. Because the homocysteine interferes with the fibrillin meshwork of the ligaments of the lens, you will have subluxation of lens. At the same time, you can see the blood vessel wall also becoming weakened, because of which the faster flow of blood will lead to injury of the blood vessel wall. That can start an atherosclerotic plaque. So atherosclerosis can also happen. So if a patient is suffering from hyperhomocystinemia, you have to convert the homocysteine faster into cysteine. We have discussed this in the previous question itself. Homocysteine reacts with serine to form cystathionin in the presence of B6. That cystathionin breaks into cysteine plus homoserine again in the presence of B6. So I will go with B6 supplementation. A patient with type 2 diabetes mellitus with increased C-peptide levels. So it is understood that endogenous insulin levels are higher. How do you confirm the type 2 diabetes mellitus to be resistance based diabetes mellitus? You can go for an index called as HOMA IR index. If it is high, the insulin resistance possibility is higher. In case of type 2 diabetes mellitus, there are two types. One is insulin resistance, that is end organ is not responding to the insulin based activity. The second thing is secretory failure. Insulin is present, the insulin's response or the response by the body towards insulin is also normal, but secretion of insulin from the pancreatic cell is not happening. That is also type 2. But if it is increased C-peptide levels, then the insulin levels are high in the blood, which is an indication for insulin resistant diabetes mellitus. And if the patient is having fatigue, it's because the insulin is not able to activate the GLUT4, because of which the glucose uptake is not happening. When glucose uptake is not happening, glycolysis is not happening. When glycolysis is not happening, ATP synthesis is not happening, the patient is having fatigue. Now they're asking you, which transporter helps in better uptake of glucose when physical exercises are seen? When physical exercises happen, the muscle proteins and muscle cytokines will activate the DNA transcription, which leads to the mRNA's translation for the GLUT4 proteins. Now, because of which from the DNA, the mRNA comes out into the cytoplasm. The mRNA goes to the ribosomes to produce the protein. The proteins are GLUT4. The GLUT4 will come to the surface. So you can expect up regulation of GLUT4 in the insulin dependent tissues like muscles and adipose tissue. And when the muscles and adipose tissue are having increased GLUT4, then reabsorption or absorption of the glucose into the cells will become better. So better tolerance of glucose happens. So the answer is GLUT4. GLUT2 can be activated only when the glucose levels are very high. So they act as sensors of high concentration of glucose. That is why they are present in the pancreas. Whenever the pancreas are having high amounts of glucose, then automatically beta cells of pancreas can produce and release insulin. At the same time, they can also be present in the liver. Liver will utilize the glucose only when all the other cells have been saturated with glucose. So it is a sacrificial kind of organ. Okay, now let's look at this question. Students did not even tell me anything beyond A. They did not remember or recollect B, C, or D. They said the 3-year-old kid with complaints of excessive biting of lips. Excessive biting of lips is an indication of self-mutilation. Self-mutilation we learn in biochemistry as a part of Vincent van Gogh phenomenon. This Vincent van Gogh syndrome means Van Gogh, a great artist, had psychological issues because of hyperuricemia, where uric acid was able to irritate the brain tissue. So he was catering to, or he was actually resorting to, going for self-mutilation by biting his own lips or fingers and fingernails. So this is a case of Lesch-Nyhan syndrome. Lesch-Nyhan syndrome is defect in salvage pathway of purines. And the most important enzyme of the salvage pathway of purines is HGPRTase. The complete deficiency of hypoxanthine guanosine phosphoribosyl transferase enzyme is Lesch-Nyhan syndrome. If there is a partial deficiency, the self-mutilation will not be there, but hyperuricemia will be there, and that will be referred to as Kelly-Siegmiller syndrome. And these have been discussed threadbare in the metabolic pathways of nucleic acids. So please go through the videos once again. This has been already discussed in microbiology. Phenobarbital or pentobarbital or phenobarbital or barbiturates inhibit which complex of electron transport chain? I have collected all the different words that have been spoken by the different class of students in this question. See, remember, complex 1 is NADH CoQ oxidoreductase. How is electron transport chain set up? We start with NADH plus H plus having the lowest redox potential. Electrons will go from there to complex 1. What is complex 1? The one who accepts electron from the NADH and gives it to CoQ. That is why complex 1 is referred to as NADH to CoQ oxidoreductase. Now from CoQ, the electrons will move to complex 3. Who is complex 3? The one who accepts the electrons from CoQ and give it to cytochrome C. So CoQ cytochrome C oxidoreductase is complex 3. Cytochrome C will actually give it to complex 4. Complex 4 will give it to oxygen. So cytochrome C to oxygen is cytochrome C oxidoreductase, which is complex 4. Succinate co-reductase is complex 2. Barbiton is supposed to inhibit complex 1 of electron transport chain. So what are the other kind of inhibitors? Rotenone, amobarbital, metformin, fenformin are all inhibitors of complex 1. Carboxin, TTFA are inhibitors of complex 2. Now there is a confusion. Does melanate inhibit complex 2? Melanate inhibits succinate dehydrogenase, because of which succinate is not entering into the TCA cycle regular steps, because of which FADH2 is not formed, because of which electron supply to the complex 2 is not happening. Complex 3 is antimycin A, naphthoquinone, and British anti-leucite target. So antimycin A, naphthoquinone and British anti-leucite inhibit complex 3. Complex 4 is inhibited by cyanide, azide, carbon monoxide and hydrogen sulfide. Oligomycin inhibits FO portion of ATP synthase complex, which is made up of FO1, F1. Here O is O, not 0. O stands for oligomycin sensitivity. ATP-ADP translocase is inhibited by atracloside, a plant glycoside, also by a pseudomonas toxin called as bongregate. Exotoxin of pseudomonas called as bongregate. Now, this is a very common question that has been asked, a very simple question paper. In the Lineweaver-Berke plot, they had put this particular picture and they asked it is showing what kind of inhibition. You don't have to break your head much. Remember, this is a double reciprocal plot. So this is 1 by velocity on the y-axis and 1 by substrate concentration on the x-axis. Now, when you try to have this red colored line, which is inhibition, the red colored line is touching the y-axis on the same point as uninhibited condition. So it means 1 by V not changed. That means V is also not changed. If V is not changed, Vmax is unaltered. Vmax is unaltered means the core property of the enzyme is not destroyed. When the core property of the enzyme is intact, maximum velocity is still attainable. So if you increase the substrate concentration, you can overpower the inhibition. So that speaks about reversibility of the inhibition. Point number one. So it is competitive inhibition where you can compete with the inhibitor using substrate. The inhibitor is competing with the substrate. Now if you want to compete with the inhibitor, you raise the concentration of substrate. And now when this inhibition is there, and the substrate is not able to bind, substrate is waiting for the chance to go and bind to the enzyme. The moment substrate binds, the enzyme will show its true power. But if it is non-competitive inhibition, then the enzyme has been poisoned, because of which the core property of the enzyme is lost. If the core property is lost, Vmax itself falls down dramatically. If Vmax is falling, then 1 by Vmax is rising. So this is normal 1 by Vmax. This is higher 1 by Vmax. It indicates Vmax is lesser. This is the point to ponder in case of non-competitive inhibition. So here you will realize that the inhibition against non-inhibited or uninhibited situation, the arrow mark is touching here. It means 1 by Km in the negative area is changing from this position. I'll zoom this area. This was the original minus 1 by Km. This is the altered minus 1 by Km. Now from the negative side, if you're moving from here to here, the value is becoming bigger. That is, it is moving towards positivity. But because the 1 by Km value is actually decreasing, you will be able to notice that the Km value is increasing. When Km value increases, the affinity between the enzyme and the substrate is decreasing. That is the property of enzyme inhibition using competitive inhibition. If it is non-competitive inhibition, because the substrate is not competed with by the inhibitor does not bind to the active site, there is no competition. It means to say that the affinity between the enzyme and the substrate is not affected, but the core property of the enzyme is affected, because of which Vmax is falling. Look at this question. Serum coproporphyrin levels are increased in which occupational lung disease? Coproporphyrin levels or any type of porphyrin level elevation is a case of porphyria. Porphyria has become dangerous in any kind of occupation where the patient is made to ingest or inhale lead. So the answer here is lead. Now have a look at this. This has been picked up from research papers. Accompanying the well-recognized increased urinary excretion of coproporphyrin 3 in lead poisoning, there was a concomitant increase of coproporphyrin 1 also of the total porphyrin excretion. It is suggested that coproporphyrin 1 and 3 are synthesized independently. Coproporphyrin 1 is associated with proliferation of marrow cells as distinct from that of coproporphyrin 3, which is linked with the formation of hemoglobin within the cells. This paragraph tells you that 1 and 3, both of them are independently synthesized, and both of them can actually be increased and found in urine in increased levels whenever there is an exposure to lead poisoning. Here, lead has two toxic actions in hemopoiesis, the basic concept. That is, lead interferes with the normal maturation of erythroid marrow cells, because of which stippled cells, lead-based stippling, can actually be noticed, which are rapidly broken down by the reticuloendothelial system, because of which hemolysis increases, which may lead to jaundice also. Now, hemoglobin synthesis in the precursor cells is inhibited probably by a general action of lead on the enzymic formation of porphyrin and other intermediates. Now, this is a regularly known thing. Lead has a very strong effect of inhibition on delta delta aminolevulinic acid dehydratase, where delta ALA cannot become porphobilinogen, so delta ALA levels will be elevated. At the same time, lead is capable of inhibiting ferrochelatase. Because of its protoporphyrin 9 also will be elevated, so protoporphyrin levels can be elevated. By backflow, coproporphyrin levels also can be elevated. Now, lead is capable of causing high levels of coproporphyrin, protoporphyrinogen, and protoporphyrin also. Elevated serum coproporphyrin levels are associated with lead poisoning. This condition can occur in various occupational settings where individuals are exposed to lead, such as in battery manufacturing, construction, painting, and certain types of metal work. Lead inhibits the enzymes involved in heme synthesis, leading to accumulation of coproporphyrin in the blood. A very simple, straightforward question. Now, this is the question that we have already discussed. I said 1-month-old child, vomiting, diarrhea, hepatosplenomegaly is noticed, and jaundice is noticed. And if at all there is cataracts with E. coli sepsis, you can easily identify it as galactosemia. If it is classical galactosemia, then there is a deficiency of galactose 1-phosphate iridyl transferase. Done. So now let's look at a few questions which were brought to my notice without complete form of the MCQs. So we'll not have much of options in the MCQs. We'll just discuss the most important concepts for your future uses. One such question was, they said the patient was a tall male adult with a long arm span. Pectus excavatum was noticed. Now, some students said cardiac abnormalities were present, some students said they were not present. Whether they are present or absent, it doesn't matter, because from the first three concepts, you understand the diagnosis to be Marfan syndrome. Now, this Marfan syndrome clinical features will be similar to one more condition or the MCQ which we discussed just now a few while ago, which is hyperhomocystinemia. Now, when you learn about these conditions in ophthalmology, you'll realize in hyperhomocystinemia also you'll have subluxation of lens, and in Marfan syndrome also you'll have subluxation of lens. The difference is that in hyperhomocystinemia you'll have inferior subluxation of lens. In case of Marfan syndrome you'll have superior subluxation of lens. The superior subluxation of lens, where the lens is trying to come above the socket, where the subluxation in hyperhomocystinemia is below the socket. This is called as sunrise sign. This is called as sunset sign. But the core concept is the same. In both the conditions, the defective protein would be fibrillin. When I told you about the case of hyperhomocystinemia, I told you homocysteine interferes with the fibrillin meshwork formation. At the same time, in case of Marfan syndrome, fibrillin formation at the genetic level itself is defective. So when the fibrillin is defective, you don't have to look beyond this in any kind of options. The protein defective has to be fibrillin. There are some questions about elastin and collagen also. You will be reading them in a bigger topic called as collagen vascular disorder. But the ultimate defective protein will be in the fibrillin. This is what I would want you to remember for the exams. Now, the other question that you should remember is, this is a medicine or surgery based question about ileal resection. And they had asked, in ileal resection, which of the following is not found? Remember, I have already discussed ileum is the site of absorption of B12. So, ileal resection leads to B12 deficiency, vitamin B12 deficiency. If it is vitamin B12 deficiency, or in case of jejunum being resected and there is folate deficiency, in both situations, you will expect megaloblastic anemia. You will expect megaloblastic anemia. Now forget about the jejunum and folic acid for a while. We focus only on ileal resection. When ileum has been resected and removed, B12 deficiency happens, which leads to megaloblastic anemia. Students said in that question, first option was microcytic anemia. If you see microcytic anemia, it may be a case of iron deficiency anemia, but not a part of B12 deficiency anemia. So that is the best answer. What is not found in ileal resection would be the microcytic anemia. What are the other features you can see? See, you can also expect asynchrony in the cytology of nucleus because of poor maturation of the DNA. At the same time, you can expect subacute combined degeneration of spinal cord, which can be seen as neurological manifestation. Other neurological manifestations including memory failure like a dementia can also be seen, but what you cannot see would be microcytic anemia. I hope this solves your question. Next, there was one more question on iron deficiency anemia beyond what we have already discussed. In iron deficiency anemia, the serum iron will be lesser. At the same time, storage form of iron called as ferritin is also lesser. While transferrin is apotransferrin plus that of iron. And the iron is ferric iron. Ferritin is apoferritin plus ferric iron. Now the transferrin saturation means for the given protein how much amount of the proteins are carrying iron, right? So that is also lesser because iron is deficient, but the body is hungry for iron, so total iron binding capacity will be higher. This is what we have discussed, and the peripheral smear picture will be microcytic hypochromic anemia. Now the question was, what is about the transferrin saturation? Transferrin saturation is decreased. This is the only simplest of answer you have in case of iron deficiency anemia. And there is one more medicine question or pulmonology question. They said the patient is suffering from pan-acinar emphysema. Because pan-acinar emphysema, the patient is having respiratory distress. Now, if this is the case discussion, which of the protein is defective is what the students asked. They said surfactant is deficient. Some students said the surfactant was of two types. One option had surfactant 1 type or type 1 or surfactant type 2, they had said. In case of surfactant deficiency, respiratory distress syndrome can be noticed, because surfactant is important for keeping your alveoli intact. When surfactant deficient, respiratory distress can be seen. But when they say pan-acinar emphysema, which causes respiratory distress syndrome, then surfactant is not the reason for it. And they said albumin, prealbumin, or transthyretin, I'm not very sure whether these proteins were defective. They said they are not known to affect your lungs to cause emphysema. But you all remember in electrophoresis, if you look at the pattern, first you have albumin, then alpha 1, alpha 2, beta 1, beta 2, and gamma, right? So in the alpha 1, which protein do you think of mostly? When I say alpha 1, what other word comes along with the word alpha 1? Yes, it is alpha 1 antitrypsin. So alpha 1 antitrypsin deficiency will be the answer for the question where the patient is having respiratory distress because of pan-acinar emphysema. And why is antitrypsin important? See, there are many MCQs, including clinical cases, that you'll come across in alpha-1 antitrypsin deficiency. For example, you can have homozygous presentation and heterozygous presentation. Which is worse? The homozygous presentation is worse. They say PIZZ. Rings a bell? Yes. In case of alpha-1 antitrypsin, complete deficiency can be seen in homozygous, partial deficiency can be seen in heterozygous. Antitrypsin is against trypsin. Now, that alpha-1 antitrypsin is known to inhibit the enzyme elastase. While elastase is the one that is supposed to break the elastin, which is present for the elasticity of the alveoli or alveolar wall. If a patient is a chronic smoker, the smoke will contain nicotine plus carbon dioxide, which is capable of activating the neutrophil elastase. When the neutrophil elastase levels are elevated, and if the patient is having general deficiency in alpha-1 antitrypsin in his life, then his Regular low levels of alpha 1 antitrypsin will not be able to inhibit the elastase. So every time he smokes, the nicotine which activates neutrophil elastase, the elastase levels will be more than the alpha 1 antitrypsin inhibition, because of which elastase can break the elastin, because of which elasticity of alveolar wall will be lost. So the ballooning activity of your alveoli can be seen, which can be seen as emphysema. Now, even in the absence of smokers, normal inflammation or infection of your lungs can lead to elastase release from the neutrophil, because of which again emphysema can be noticed. So in this case of pan-acinar emphysema causing respiratory distress, the protein deficiency you can suspect would be alpha 1 antitrypsin. Dear students, we've come to the end of biochemistry MCQs. We'll just have one MCQ to deal with, but that MCQ can be a part of both microbiology and biochemistry. The question was like this. The student said that it was meningococcal meningitis. Some students said it is just Neisseria meningitis. Till now, nobody had called it as gonococcal meningitis, so we safely assume it can be meningococcal meningitis. If you want to make a highly sensitive investigation, what PCR will you do in case of meningococcal meningitis? The options they said were nested PCR, RT-PCR, and multiplex PCR. Here I can assure you of one option that can be eliminated easily, which is RT-PCR, reverse transcriptase polymerase chain reaction. Reverse transcriptase polymerase chain reaction is used in molecular diagnostics for RNA viruses. Because we understand very obviously that the meningitis is caused by meningococcus, which is a bacteria and not a virus, and we are not targeting an RNA virus, we can eliminate RT-PCR from the equation. Now, nested PCR, multiplex PCR, both of them can have their own merits. Both of them can be chosen in the question. But what are the advantages and disadvantages? Nested PCR is known for high sensitivity. What does this mean for us? Even if the CSF sample is containing very low particles of the meningococcus, it is still capable of identifying. So, identifying even very low microbial presence or microbial DNA presence. So, why don't you go for nested PCR then? Why are you going for multiplex PCR? The problem is that when you say meningitis, if it is meningococcal meningitis, if it is already known that it is meningococcal meningitis, going for nested PCR is absolutely fine, because you know you are suspecting meningococcal meningitis because in the CSF sample you are seeing gram-negative diplococci. But if you don't know it is meningococcal meningitis, or if you just know that it is pyogenic meningitis, which is some bacteria, then any cause or causative microbe might be behind the meningitis. So multiplex PCR can be taken into consideration. So multiplex PCR has a wide array or wide options to diagnose from, but it has slightly lower sensitivity than that of nested PCR. So you have to ask yourself, what is the setup that you have? If you really want to identify even the lowest values of the microorganism present in the CSF or from the sample given, if you need very high sensitive PCR, go for nested PCR. Why is so? Because it uses primers from two different sources, or two different primers are used. That is why the sensitivity is very high. But if you don't need such kind of sensitivity, but you want to cater to the needs of wider causative agents, then you can go for multiplex PCR. So in meningitis, if you don't know what the causative organism is and if it can be any causative organism, going for multiplex PCR will be practically viable. So from the point of view of meningitis and meningococcus, it can belong to microbiology. But from the point of view or PCR or nested or multiplex PCR, it can be biochemistry or molecular biology. So I hope you will be able to use these kind of thought processes and concepts to crack your questions in the future. And please go back and revise all the videos and crash course videos in the Manipal Middays app. Every question in this particular MCQ discussion are discussed and are already discussed in the app. All the very best for your future exams.